Hello everyone, presenting a case of UBE discectomy with the caudal migration of disc at L5S1 level, which we can see. This is caudally migrated disc, acute fragment, mainly on left side. So we started left-sided UBE procedure. So in this case, decompression was mainly focused on lower lamina, and in such type of cases we need to plan accordingly the port sites, because this was caudally migrated, so ports were slightly shifted caudally, so that it should be easy to take out that caudally migrated fragment. So initial steps are same. The only difference is that we don't need to go cranially too much. So just slight drilling of cranial lamina and a lateral drilling of facet joint. Then neural structure we can see, and just by clearing some soft tissue with bipolar radio frequency bipolar. So this is axilla and traversing root. So we can see there is lot of adhesions, lot of new vascularization because of this disc bulge. So disc is there. So discectomy is performed in a regular way. Initially there was just this bulge which was visible, so we decided to take this bulge out, and we were just trying to look for another big fragment, because this was not the fragment which was apparent on MRI. So we just slightly retracted neurostructure medially. Then there was acute fragment which was visible, so that fragment was quite large in size. And this fragment was gradually mobilized and was taken out. So we can see this large fragment, this was taken out. So now root is free, small fragments under the root, these all the fragments they are taken out with specialized curved disc forceps or pituitary forceps, which is specially designed for such type of cases and very useful in a UBE surgery, whether this is a discectomy or decompression. Especially for contralateral work, this curved instrument or curved disc forceps is really very useful. So this is axilla. So large fragment was taken out from this axilla, which was medially placed. This is lateral recess, which was bipolarized, cauterized, so that future or recurrent disc herniation can be prevented. So radio frequency is used here in lateral recess and in the axilla also. Initially it was looking that we took all the relevant disc fragment which was visible on MRI, but on careful inspection we saw another fragment which was still caudally situated, placed. So then we decided to do little more decompression caudally, because this was quite large fragment, so was not coming out easily, and there was adhesions also, most likely because of chronic inflammation. So caudal lamina was further drilled and this was further decompressed. Then this adhesion, all the adhesions, they were slightly released with the help of radio frequency. So once this large disc fragment, which was caudally migrated, once this was mobilized, then this was taken out with the help of again this curved disc forceps. So this entire large fragment we were able to take out. So now we can see there is a large defect which was created by this extruded caudally migrated fragment. So which was further confirmed by X-ray on CM images. So this was almost up to the level of S1, S2 level. So now we can see how caudally this fragment was migrated. So thank you.